I would like to introduce Dr. Ranjitha Tiwari, which definitely she doesn't require any introduction now, but not a small introduction. This is, I want you to know that what is her achievements. Born and brought up in Hyderabad, southern state of India, pursued her bachelor's in veterinary science from the then Andhra Pradesh Agriculture University, Hyderabad, master's in genetics and breeding from National Dairy Research Institute, Karnal, then moved ahead to United States of America to pursue her integrated PhD, wherein her PhD research was on autophagy. Moved back to homeland and started clinical practice entitled Hope Animal Clinic in a small town in the outskirts of Hyderabad. Later pursued course in cardiorespiratory medicine under the mentorship of Dr. Naik Bezring from College of Veterinary Education, Sydney University. Has attended multiple national and international symposia, both human and veterinary ones. Owning her knowledge in comparative veterinary cardiology, she also attends many human cardiology webinars, ECG and structural heart diseases, and is a member of 3 human cardiology societies. In lieu of creating awareness towards the crucial discipline of veterinary cardiology among the fellow veterinarians, Dr. Ranjitha has been managing 2 serious WhatsApp study groups teaching exclusively veterinary cardiology, namely Vet Guardians 1 and 2. During COVID period, Vet Guardians have achieved the honor of delivering 27 webinars exclusively in veterinary cardiology, and that too by the Vet Guardians members themselves. She has been an invited speaker of veterinary cardiology at various state associations like Pune and Kerala, has delivered multiple, latest by Guwahati also, has delivered multiple online national and international webinars, and was the invited speaker at first ever national symposium in canine cardiology. Dr. Ranjitha has been invited to teach echocardiography in small animals by Sri Lanka Veterinary Association, thus becoming the first Indian veterinarian to teach veterinary echocardiography to foreign vets. Dr. Ranjitha strongly believes in 3 concepts. Firstly, every patient is cardiac compromised to some extent. All it needs is to identify and stage it. Secondly, the development of establishment of veterinary cardiology as a crucial discipline can only be achieved through mutual education and honest referral. Thirdly, spreading awareness of cardiac health, both among veterinarians and pet parents, is a huge responsibility of every veterinarian. After all, it's about heart we are referring to. So with that, Dr. Ranjitha Tiwari is here. She has been a mentor to me and Orihil Life Sciences too. Our cardiology range entirely is been dedicated to Dr. Ranjitha Tiwari. The why we have launched the most affordable and economic range of cardiology that was being suggested by Dr. Ranjitha Tiwari itself. She told us that this is a range of medicines which is required for whole life, and it has to be very pocket friendly and affordable for pet owners too. Because if vet recommend expensive medicines to pet owner, then either pet owner stops giving that medicine or reduces the dose. In both the ways, our patient suffers. So Orihil Life Sciences, with that idea, launched one of the most economic pimobendan and cardiac support formula. And thank you very much, Dr. Ranjitha. This idea has been welcomed by veterinarians, and we always tell everybody this is due to Dr. Ranjitha Tiwari only. Thank you very much.
Good afternoon, everyone. Thank you, Dr. Vishal. Am I audible?
Definitely, you are audible.
Okay, thank you very much for that introduction. And once again, I am extremely obliged to Orihil Life Sciences for doing tremendously good job, both in terms of economics as well as the range of products that you guys are getting. I'm very happy. I have been using your entire cardiac range, and definitely it has been extremely helpful in maintaining the continuity of treatment. So we not only, and we make sure that we let pet parents know about it. We sometimes even have to run how much it costs for the entire month. It's not easy, especially post-COVID times. It's become very, very difficult. And especially if a dog is around 30 kgs, it becomes even more difficult. So we must be thankful to you. Thank you very much. And definitely, because you are a vet, only then you can understand the difficulty of progression in India. Thank you. This is the second session, gentlemen, and we are talking about one of my most favorite modalities of diagnosing a cardiac patient, that is ECG. And to be honest, my very journey of cardiology has begun with one lecture in ECG, so which I'm extremely thankful to Dr. Sangeeta ma'am. It was her lecture that I started my journey. And so when it comes to ECGs, I keep going on and on. But trust me, most of the ECG lectures we always find they're very boring and they're very kind of theoretical. Yes, they are theoretical because that is what is science about. So I will. So my very concept of handling today's lecture would be, we'll try to make it as simple as possible for you to identify whether a rhythm, whatever you're seeing the ECG, is normal or not. And then I will make sure that I help you understand how to correlate that ECG. And finally, we will be definitely handling the treatment part. So I have worked quite hard on giving you, making this very simple tables. So don't have to butterfly, don't have to remember all those things. Click the pictures and make sure that you put it on a table. Okay, but more than anything, more than knowing what heart medicine to be used, it's important to know when to use it. Okay, so let's start the lecture. I'm trying to share my presentation. So shall I start now?
Yes, ma'am.
Okay, let's start. So today's topic is cardiac arrhythmias in small animals. So we will try to understand how easy it is to read a rhythm and to know if it is normal or abnormal. And so we'll try to classify. There are beautiful, many classifications available, and making it more a complex subject. But here we are going to just do it only which is absolutely clinically relevant and the basic ones for our study purpose. Okay, so let's start. So we all know what heart is, right? It has 4 chambers, 2 in the top and 2 in the bottom. We all understand. We have to understand the basic anatomy of the heart, right? So the 2 top chambers and 2 bottom chambers, we know the top chambers are called as atria and the bottom chambers are called as ventricles. Gentlemen, I want you to understand that the entire contraction, whatever the beat that you're listening, is only because of the contraction of the ventricles, not the atria. Atrial contractions are important just to maintain the cardiac cycle. It's important to empty the atria, okay? Whatever the pumping you're seeing, it is only because of the ventricles, right? So the entire heart, the entire system of functioning, it is neurohormonally regulated. However, the pressure differences is what is going to create your cardiac cycle. Okay. Now, what is this? We have dealt this even in the last cycle. So I don't know how many of you are attending the lecture for the first time, but many of these slides are taken from the previous lecture just so that we can get into the rhythm of understanding things. Okay. So this is the electrical conduction system of the heart. What you see here are the green lines and a red heart, okay? So the red heart shows that it is all myocardium, and the green lines doesn't mean it is green inside the myocardium. It's just the specialized cardiac cells which are responsible for generating the electrical system, generating the electrical conduction. Because of that electricity, because of that current itself, the heart is going to have that muscular contraction, therefore creating a beat. Okay, so it doesn't mean that it is green in the heart. It's just the depiction, right? So the entire green system are specialized cells which generates and which conducts the electrical current, and the rest of the myocardium is meant for the contractility. Now, this does not mean that the rest of the heart muscles, which is not green, is not capable of producing electrical current. It is capable of doing that, and we will see how significant it is during when we are talking about arrhythmias. Okay, I want you to remember this point here. So, absolutely crucial slide. Don't worry about the terminology. Let's see here and try to understand. What I'm trying to tell here is heart muscles have got the capacity to generate the electrical conduction, electricity, to generate the beat electricity, and then it is capable of stimulating itself. It's capable of transferring that electrical current from one place to the other. And because of the transfer of electrical current, what's happening is the electrical current is going to get converted into the muscular mechanical current, and that's why it is able to contract. Once it contracts, the heart muscles have also got the capacity to relax itself so that it can get into another cycle. Okay, generating the current, getting excited, conducting the current, creating the contractility because of the conduction, and finally it is able to relax itself. That is called as a refractoriness. Absolutely crucial properties of the cardiac muscle cells. Okay. So I just told you it has two different, nothing but the conductive myocardium and the contractile myocardium. It's just a descriptive thing. Now let's try to understand what makes a heart muscle cell so special. Now, whenever we talk about this is inside, that is inside, it just gets very difficult, right? So try to understand that in a heart muscle cell is something like a bag of potassium which is soaked in a cup of sodium. Just remember it that way. It's very easy, okay? In a normal heart muscle cell, all the potassium is inside. All the potassium mostly is inside, okay? Now, so outside the cell, you have sodium and calcium, which is very rich, okay? Whatever the current which is generated is only because of these ion exchange properties and because of all the kinds of ion pumps which are present on the membrane of the myocardial cell, okay? Now, this might look a little complicated, but it is a very, very simple thing, and it took me, many hours to make the slides. I just want you to just pay attention for about 2 minutes here. So the entire red box is nothing but one myocardial cell, okay? And then you see half of the red box, it means which is the second myocardial cell, okay? The beauty of the heart muscle cells, unlike any other muscle, is they are arranged right next to each other, and they are interconnected by the gap junctions. It means they are interconnected. Now that's what it makes a syncytium, right? It is called as a syncytium because it is it is connected to one another and it is maintained in succession. They are one next to the other, okay? And because of these gap junctions itself, we are able to pass the signal from one cell to the other. That's the reason the heart is able to contract in one direction. All myocardial cells able to contract in one direction. Like any other cell, every cell has got innate current, its innate potential, and that is called as a resting membrane potential. We all have studied this on the way back, okay? Now, whatever this resting membrane potential is there, all the description here I'm just trying to tell you is about this simple, any general myocardial cell, okay? Now, minus 90 is considered as the resting membrane potential. All this description, gentlemen, is about the human myocardial cell, which has been extrapolated in the veterinary medicine. We don't find any difference in the membrane potentials, okay? Now, in due course of time, whenever cells end up having a signal, a small stimulus, then there are the sodium, which was more on the outside, it starts seeping in. And to compensate that extra sodium, the potassium seeps up. The cell always has its mechanism to make the equilibrium, right? So this keeps going around till the minus 90 millivolts, it gets more onto the positive note. So till it becomes a 0 millivolt thing, so this is called as a threshold membrane potential, where the cell gets badly stimulated, and because of the stimulus, lots and lots of sodium cells, they're called as a rapid influx sodium channels, they open, and more of sodium is coming out. As the more and more sodium comes out, then compensate, more and more potassium keeps going out, right? So during this is called as the phase 1, okay? Phase 1. So once the phase 1, you reach the phase 1, then what will happen is, once there is lots of sodium influx happening because of the heavy sodium channels, the rapid fast opening sodium channels which are open, then this triggers what you call as the calcium ion channels to open, and so now the calcium also starts seeping in. It means the cell becomes more and more electropositive. So what's happening here? Cell which was more electronegative, that is minus 9 millivolts, is becoming more and more electropositive. So what you're doing, you're changing the polarity of the cell. So what you're causing depolarization. Whatever was the polarity, we are taking it onto the opposite side. You're depolarizing as a cell. So a depolarized cell is nothing but a stimulated cell, right? So this depolarization phase stays for a little longer because calcium channels, they're kind of weak and slow, and they slowly open, they slowly close. Till that time, this thing is maintained. Now, once this calcium channel closes down, so this slow phase is called as a phase 2. Now, once the calcium channel closes down, then the more of the influx of the positive energy is stopped, but potassium is still leaving. They're still leaving. The potassium has not stopped going out. So eventually, the potassium keeps going out and out and out to an extent where you again reach the resting membrane potential of minus 90 millivolts. So what cell is trying to do? As it gets stimulated, it becomes more and more becoming electropositive. It means it's getting depolarized, and still the potassium leaks out, so that at the end of the day, at the end of the stimulation, it becomes repolarized again. It gains its own negative polarity again. Okay. Now, during this process itself, when there is so much of ion exchanges going around, the ions from one cell to the another goes into the next myocardial cell, and that is what is triggering the next myocardial cell. Okay. Now, the very reason when I'm trying to spend a little time on this slide is it's very important to understand these so that we can differentiate between a regular myocardial cell and a nodal myocardial cell. What is a nodal myocardial cell? We know that there are two pacemakers, right? Actually, there is one major pacemaker that is called the sinoatrial node. This sinoatrial node, we know that it is different from the rest of the cells, rest of the myocardial cells. Why? Because it is continuously producing energy. It means it is continuously in the phase of depolarization. You do not see that plateau. I'll show you again. You see that phase 2? You do not see the phase 2 in the SA nodal cell, okay, or even in the AV nodal cell. You do not see that thing. That is the reason it is continuously getting depolarized. There is no big phase of repolarization again. So that's why in a span of about a minute's time, an SA node is capable of producing 300 signals per minute. It is firing 300 signals per minute. Okay. So this slide is definitely a keep. It is to help you understand theoretically why SA nodes and AV nodal cells are, or the Purkinje cells are different from the rest of the myocardial cells. That what makes them conducting myocardium when compared to the rest of the myocardium. Okay? So because there is a difference in their membrane ion types, so keeping them in a longer duration of depolarization in SA nodes. Similarly, this, what happens in AV node, the structure of the AV node is arranged in a way that the cells are arranged in the form of a plaque, one next to the other, so that the signals which are conducted from one plate to the other, another plate, it just slows down, right? That's the reason in AV node we say that the AV node works as a filter, it works as a seal. If there are about 300 times the firing is happening in the SA node, in AV node, by the time it comes down to the AV node, it comes maybe in humans, it will be like 70 to 80 signals which are going down. That's what makes our beats are 70 to 80 beats per minute, because it is said that in a normal cell, every single signal which is passing below the AV node, passing through the AV node, is definitely it must be conducted through the entire myocardium and is equal to generate one beat. Okay. So here, when I'm saying every single signal should go down, if there is any variation, it means if there is any block to the passage of the signals, we will be talking about those things later, which are called as the AV blocks. Okay, it is definitely an arrhythmia. So understanding these basic things right here is extremely important. Okay, now Purkinje cells, if the sensation, the layers are arranged as a one next to the other in AV nodes, they are arranged one right next to the other longitudinally, and it has more and more of the calcium channels, which are slow, and with those calcium channels, the extra channels will allow faster depolarization of the cells, and that's why it makes them like the signal passes just like that, very quick in the bundle of His, okay, and Purkinje cells. So this gives a depiction. What I just talked about is in atria, the speed is 0.5 meters per second. As when the conducting speed is 0.5 meters per second. In the bundle of His, it is 10 times slower. In AV node, it is 10 times slower. In bundle of His, it is 2 meters per second. It's very, very high. And even in the Purkinje fibers, it's very, very high, like 4 to 5 meters per second. So the faster signals, all once the signal is transferred very fast to the myocardial cells, then that's where the contraction happens. See, all these things happen in fractions of a second. That's the reason you're able to generate so many beats per minute, okay, based on the heart rate. For example, we all know that the smaller breeds have higher heart rate, the larger breeds have smaller heart rate, but imagine the heart rate in cat. It's about 20 to 200 to 220 beats per minute. So in 1 minute, all these things are happening. How many times? 200 times, okay? Now, coming to the practical viewpoint, how the leads are placed, why important these leads are, because your sinoatrial node, which is present in the right atrium, you see here, this is sinoatrial node, which is present in the right atrium. The current is produced and it is transferred through the atria. The atria then contracts, and whatever the signals they are passing through the AV node, that is atrioventricular node, they go through the bundle of His and the Purkinje fibers, and it leads to the contraction of the entire ventricular myocardium. So the signal, the plane of signal is going from the right atrium towards the left ventricle. It's from the right atrium towards the left ventricle. You can imagine it is going from your right hand towards your left leg. And that is what we read about is the lead 2. The orientation of the lead 2 is also towards from the right atrium, right arm to the left leg. That is the reason in veterinary medicine, basically, that is a maximum deflection, okay? So in veterinary medicine, we say we study the lead 2. You can also read the deflections in lead 1 and 3, but basically you study in the lead 2 because it's the highest deflection. It is easier to read, okay? Now this video I have played before, so I also want to play it again to help you understand how I place the leads and how I take the reading. This is the standard convention which I have followed. So let me know if you're not able to hear the audio. Please let me know, Dr. Vishal, I'm playing it now. Okay, so while I'm playing the video, I'll just tell you what I'm doing here. So I'm placing my patient in the right lateral recumbency, and then I try to trim off the hair of all the 4 limbs when I'm planning to place the leads. So leads basically I like putting in my flanks or on the elbow region, but there are other spots too, like here or here, all those spots can be used to place the leads, but I just find it more convenient there because it is very thin skin, it's easier to place. And so once I remove the hair, I take a wet sponge to clear off whatever the remnants of hair are so that I don't get any interference, and it's easy conduction. And also sometimes, using a wet sponge also helps in avoiding the air gaps. And then I use some, you can use the ECG gel or even an ultrasound gel or even the spirit you can use to place your electrodes. So having these coupling things will help you avoid the interference because of the air gap or, because of anything like remnants of hair or anything. So just a small little piece of gel, I'm applying it over there. And then I start placing my leads or the electrodes. So these clips which I'm using, they are non-invasive clips. So the machine which I'm using is a very simple ECG machine. It's a single channel BPL machine, and I basically use only in the manual mode. And whenever I'm doing this, I'm all set with my machine. So I'll do in a manual mode, and I'm selecting the lead 2. So what I'm showing here is that these are simple clips which are non-invasive. They're not alligator clips. They're flat ones, and they're absolutely non-invasive. I normally try to put it on my delicate skin and try to show it to the pet parents that it is absolutely invasive, non-invasive, and it doesn't hurt the pet. Sometimes, if you are not able to get the proper signal, so you can also, and the patient is very sensitive, then you can even use a little bit of wet tissue, okay? Put it over there, and then you put your clip over the wet tissue. Even that would work. Okay. See, my patient is already tachypneic, so I allow the pet parents to hold. So both of them are pet parents. They are not my assistants. So I always ask them to be around so that it gets easier. Okay, so when I'm taking the leads, when I'm taking an ECG, I take first the preliminary ECG is at lead 2. I take a small strip of at speed 25 just to look at it and assess if my rhythm is in regularity or not, and then I take a long strip of same lead 2 at speed 50 so that I can study each and every waveform. Okay, and then you just take off your leads and you're done. That is how you do, take an ECG of an animal. Here on the right side, what you see is a simple trolley. So this is a mobile. My machine is always, it's moving around because I'm a referral. My clinic is more like a referral clinic, so I keep getting emergencies. So my ECG machine is running around in all my rooms. Okay. So here, again, just a small refreshment of your leads. That is, since the lead 2 is oriented from the right forelimb to the left hind limb. It is in the direction of the passage of the signal. That is the reason it gives the maximum deflection, and that is the reason why you study lead 2. Okay. Now let us come and look at the PQRS form. How would this PNQ and RSR form? So whenever the signal is produced from the SA node is firing and it is producing a signal, and so this signal is transferred to the entire atria, that is left and the right atrium, and then it causes a depolarization. So basically you have to understand that ECG machine is nothing but a simple galvanometer which converts the electrical signals which are received by it into the magnetic, and it shows onto the strip in the form of a wave. Okay, what you see, the first positive bump, the bump towards up. So when you look at the ECG strip, on the y-axis is nothing but the maximum deflections. It talks about how much voltage it is, and on the x-axis it's all about the time period. So how long is that waveform lasting? Okay, so the first positive on the top, the first positive deflection is nothing but your P wave. P wave is formed by the contraction of both the atria. Once the atria contracts, the signal, whatever which is passing, that is generated from the SA nodes, they contract the atria and then reach the AV node. From the AV node, it quickly passes down to the bundle of His and the Purkinje fibers. So this bundle of His is basically nothing but your interventricular septum. So the current is passing through the interventricular septum. You see the first negative deflection, right? The first wave which is going down, the negative deflection, and that is nothing but the Q wave. Once it passes through the interventricular septum, then the Purkinje fibers take, and there are hundreds of divisions of the Purkinje fibers. It is spread throughout the ventricular myocardium. When the signal is passing through that, that is when it causes the contraction of the entire ventricular myocardium. And you know how big is the ventricular myocardium? Let me show you. There's a hand thing I have here. So this entire thing has to get contracted. So it takes longer time, it takes longer voltage, right? It takes higher voltage and longer time. That's the reason you see the highest positive deflection, that is the pink wave, that is R wave, huge ones. Now, by the time, see, it is coming down here and it is going down up here. So this little here, by the time it goes all the way up here, the contraction goes all the way up here, that's when you end up having a small negative deflection again, because it is in the opposite direction of the conduction. Okay, I told you it is from right to left, right? It is from the right atrium to the left ventricle is what is and you're reading the lead 2. So it is, the contraction is happening in the opposite direction. That's the reason you're getting again a negative deflection there. That is the S wave. And once the contraction of the myocardium happens, the end of the day, what you have to do is they have to relax again so that it can take up the next waveform, right? So that relaxation phase is nothing but the T wave, and T wave is again, it can be positive, it can be negative, it can be biphasic. In veterinary medicine, the significance of T wave is not hugely with respect to the arrhythmias. That's what we basically say, except for a couple of them. So T wave significance in human medicine is very high. Why? Because they end up having any changes in the T waves is basically related to a lot of STEMI, which we call as the ST segmental elevations. Changes in the T waves are related to a lot of coronary artery diseases in humans, which fortunately or unfortunately we don't see in veterinary medicine. However, as per the recent reports, there have been reports about English bulldogs showing myocardial infarctions and also going through the coronary artery diseases. But I really don't know in our regular day-to-day life how important they are or how significant they are clinically. Okay. For now, just remember the contraction of both the atria. Contraction of both the atria will give you the first wave, that is a P wave, and then the signal comes down the interventricular septum. The signal when it's in the interventricular septum, it gives you the first negative deflection, Q wave, and then this entire myocardial contraction will give you the R wave. And this small segment here, which is opposite to the direction of flow of the current, will give another negative deflection, that is a S wave, and the relaxation is nothing but the wave. Okay. Are we good so far, Dr. Vishal?
Yes, ma'am. Perfectly.
Okay. Thank you. So this is nothing but the recap of what we just talked about in terms of the scientific terminology. Nothing but when I'm saying atria contracts, it means the polarity is changing, right? It is, so we call it as an atrial depolarization. Nothing but the atrial contract is P wave. Your QRS complex is all about the ventricular myocardium. So it is ventricular depolarization, but at the same time, the atria are relaxing. Okay, they're getting ready for the next wave. Now, T wave is nothing but the complete ventricular repolarization or ventricular relaxation. And then by the time you're done with the T wave, atria are already getting into the phase of contraction, that is depolarization. Okay? Now, let's start looking at the regular rhythm. Very, very important that we understand whatever the PQRS you're seeing, that those PQRS should always be in the normal form. Okay, for an ECG waveform. See, the image that you're seeing here doesn't mean that that is how you get it in our patients. Okay, we have quite a bit of artifacts because of the movement, because of the respiration, they panic, and if you're looking at a heart patient, they might be tachypneic, badly tachypneic. Okay, it's not easy. You're not going to get a rhythm of that beautiful rhythm. Just an internet download, guys, for you to understand. You hardly will get a beautiful strip like that. But you have to understand is to consider a rhythm, to consider an ECG strip as a normal rhythm, the heart rate should be normal. Okay, why did I mention so many heart rates here? In humans, it is 70 to 80 beats per minute. 100 to 120 beats per minute is considered as normal in small toy breeds. I'm so sorry for this. In toy breeds, and then you can have a larger beats when you come to large breeds, giant breeds. You have 60 to 80 beats as normal, and then you have 200 to 240 beats per minute as normal in cats. So we have all kinds of normal beats. So the rate should be normal, and every single waveform, that is PQRST, should look alike. They should be equally spaced from one to the other, and the gap between two R's should be normal. Only then uniform. Only then you can consider this as a normal cardiac rhythm. Okay. So in our patients, you'll see sometimes the baseline goes up and down. It's kind of okay. Sometimes you see, in succession, some waveforms, though they look absolutely good, like PQRST, and they're equally spaced, then suddenly you see a gap. And then suddenly you see all this. So you can see a uniformity in terms of some of them being quite closely placed, some of them being farly displaced. So these things are basically, it means that it could be a respiratory sinus arrhythmia. It means that whenever your patient is inspiring, when they're breathing in, you see more PQRS very closely spaced. When they are expiring, it means in the expiratory phase, when they're breathing out, they get widely spaced out. So respiratory sinus arrhythmia is also considered as a normal cardiac rhythm in our patients. Okay, they don't have to be absolutely like this. But even if it is a respiratory sinus arrhythmia also, the waveform will not change. What I mean to say is the P, Q, R, S, T, the shape and the size does not change. It is only the placement that can, some of them will be closely spaced and then some of them will be widely spaced, and this will come in succession. Okay. A very important slide. I must thank one of my vet guardians here who has made this slide, and I just stole it from him with his permission. So please go ahead, click this and paste it on your table or in your room where you do your ECGs. You don't have to memorize, but every time you read, try to read few waveforms, few PQRST waves, so that you understand whether it is normal or abnormal in this range. It's very important. Now, whenever you read an ECG, whenever you read an ECG, you have to understand that you not only look at the shape and the size of each wave, but then you try to correlate them clinically in terms of whether there is a P wave for every QRST or not, whether the QRST shapes are uniform in every single wave or not, whether the R waves are spaced one next to each other in the equal distance or not. All these things are of huge clinical relevance. I will show you a few of my clinical cases, especially the ECGs I'll show you, and I'll help you understand how important is that variation to understand what's going around in the heart. Okay? Now, we just talked about whatever is a normal rhythm. So the one which is not away from the normal is nothing but your arrhythmia. Okay, there's not much to explain about the word. However, arrhythmia in an ECG or in a strip can arise because of multiple reasons. So the definition of an arrhythmia is it is an abnormality, rhythm abnormality, which can happen either due to the signal which is not generated at the normal spot. That is, if the signal is not generated at the SA node, it can cause an arrhythmia. If the speed of the conduction from the sinoatrial node into the interventricular septum or towards the ventricle, if it is not happening in a given period of time, which is considered as normal, if it is not happening in a given period of time, then it could lead to either a faster rhythm or a slower rhythm. Then it is an arrhythmia because it is not the normal rhythm. Or if there is, the signal is generated from the SA node, but it is not conducting down. Okay, it is not going beyond the AV node, or only few of them are going beyond the AV node. Then also you will see that the signals are not passing. If the signals are not passing in the given period of time, then you will not generate the contraction of the ventricle. Okay, then also it is an arrhythmia. Okay, so arrhythmia can be because of either the site where the signal is generated, if it is not generated from there, or if it is not conducted in a given period of time, or if it is not happening like in given period of time. For example, like if it's happening slow, the current is generated slow, or if it is generated faster, then also it can lead to arrhythmias. Okay. Now, why does an arrhythmia happen? Why is it happening? Very, very, very crucial slide, guys, because if you do not understand the science behind it, you will not be able to correlate it clinically. So pathogenesis of arrhythmias either could be because of the a lack of the formation, disorders of the formation, or it could be because of the disorders of the conduction, right? Either the signals, electrical signals are not formed properly, or they are not conducted properly. These are the two main reasons why it happens. Okay, when it comes to the terminology, it means that the automaticity is lost. It means the generation capacity is either lost or it has slowed down. Okay, or whatever the signal has been generated, it's not being conducted from the spot of generation to the next. Okay, these are the two reasons why the arrhythmias happen. Now, coming to the very major part of our lecture today, there are many, many different types of classifications has been described. Whatever I have, the classification which I'm describing over here, the two different kinds, is mainly oriented only to the clinical significance. And this has been taken up from two major books, that is one by Dr. Pillay and the other one by Dr. Fox. So I have tried to concise them and try to help you. I'll try to help you understand how these things can be organized. Okay. So if in an image, I mean, if you just try to look at the heart images I'm giving there. Okay. Those yellow stars talk about where is the site of this arrhythmia happening. If the arrhythmia is happening beyond the ventricles, over the ventricles, over the where the place of the valves arise, then they are supraventricular arrhythmias. Okay. If the origin of the arrhythmia, if the origin of the signal is below, it is in the region of both the ventricles, could be left or could be right or could be interventricular septum, could be anywhere, then they are called as a ventricular arrhythmias. Okay, these are nothing but abnormal signals, right? Now, in atria, all these beautiful terminology which I'm describing down there, it needs another big class to understand what each one of them are. So, well, I might give you a couple of examples, but basically whatever arises in the atria, there could be signals, abnormal signals arising in the atria. There could be abnormal signals arising in the atrioventricular junction or in the ventricles. Okay. Now, another mode of classification is whatever these signals are being generated, okay, there could be a variation in the speed of conduction. Either it could be conducting very fast, which are called as a tachycardia. We are very well versed with this terminology, or the conduction speed could be really slow. That is called as a bradycardia. Now, in bradycardia, it means if the sinoatrial node is not able to generate the signals, then it is called as a sinus bradycardia, so it might lead to big pauses, or it might just not generate the signal at all for a really long time, which is nothing but sick sinus syndrome, which is very, very common in a pug. Okay, or it may be like, might be getting into the phases of very fast generation, then a big pause, very slow generation and a big pause. It could be like that. That is a tachybrady syndrome. Now, coming to the AV junction, that is the atrioventricular junction, very, very important they are called as blocks, AV blocks, which are very common in our field, in our veterinary medicine, in our patients. And I will take a special slide to help you differentiate what are the different types of AV blocks. And coming to the faster signals, that is, so whatever the number of signals which are generated, if they're being conducted much faster than the normal speed, that's called as a tachycardia. So tachycardia could be again because of the signals which are generated above the ventricles or maybe inside the ventricles itself. Okay. So once the signal is generated here and they are generated in much more speed and they are easily conducted, or there are more number of signals also they are originating right from the ventricle itself. Okay, as I told you, remember in the initial slides, I told you that every single myocardial cell has the capacity to fire, right? Automaticity. Every single cell can generate its own signal. It can get excited by itself. It can, conduct that excited signal from one cell to the other. It has the capacity to convert that signal into the mechanical energy, thereby causing the contractility, and it can go into the phase of refractoriness. Okay, every single myocardial cell has that capacity, and that is the reason why we are seeing so many arrhythmias. Okay. Now, I was telling you about the AV blocks. AV blocks, I mostly find them as emergencies, especially when it comes to the high degree AV block is considered as an emergency. Most of the emergency patients do show this, apart from other arrhythmias, and but when it comes to the atrioventricular block, what does it mean? Signal has been generated from the SA node. It's normal signal, but when it comes to the AV node, it will not function properly. Okay, it might cause blockage of the signals, and signals might not go down. If it is not going down, it is not conducting, and it will not generate ventricular contraction. Okay, so there are 3 degrees of AV blocks being described. That is first degree, second degree, then the third degree AV blocks. There are a little more details to the second degree also, but I'll just give you a very simple description here. And even in my vet guardians group, I really find that people find it difficult to differentiate between these blocks. So I'll just try to explain these blocks in terms of a simile, which I've heard with one of the speakers, and I really loved it. I just adapted to that. So as per the description here, consider your P wave as husband and your QRS as, sorry, both are husband. I'm so sorry here for the typo. QRS is your wife. Okay? So we are always very complex. So P wave is the husband, and if a QRS complex is the wife, then we are complex people, right? So if they fight, wife and husband, we all do that. So when you fight and husband is trying to coax, but wife is like, stay away. Okay? So eventually he's trying to coax and she goes away. It means you have, as the distance between the P wave and the QRS complexes keep on increasing in the successive waveforms, then it is called as the first degree AV block. First degree AV block is not considered as an emergency. It can still be handled. Sometimes we don't even treat them very well. We ask the patient to come back for a follow-up. Okay? So husband is trying to coax the wife, but wife is moving away. Okay? P wave is normally generated, but there is a distance of PR distance is keeping on increasing. Then it's considered as the first degree AV block. Now, the quarrels further increases. So, and the husband continuously tries to make his own attempts, repeated attempts of trying to help wife understand. It's okay, let's try to, calm down and all. And wife is like, sometimes she just shuts the door. She gets into another room and she shuts the door. She just doesn't listen to the husband. Yeah, all men can smile now, it's okay. So it means you see multiple P waves. You see multiple P waves, but few QRS complexes. So you can see that there could be waveforms where you see multiple P waves, but no QRS at all. Okay, then it is considered as second degree AV block. Okay, now the quarrel further increases. They just get into the fight. She just leaves and goes to his mom's house. No matter what, husband trying, wife not listening, everything getting deranged. Okay, there is no specific rhythm. Okay, then it is considered as a third degree AV block, intense one, where you end up getting into a divorce. Very bad. So when it comes to a third degree AV block, you cannot have a specific pattern or a rhythm. Okay, there could be multiple things that's going around. You can see even an AV dissociation also. Atria and ventricle just going erratic. There is no way of getting back. What is the treatment for a third degree AV block? Ideally, installation of another pacemaker is considered as the right treatment. Usually you end up seeing a third degree AV block as an emergency patient only. Okay. Now let me show you a couple of my clinical ECGs so that I can help you understand how these changes in the waveforms, you can correlate it with the clinical patient. Okay. Just a quick brief from a last slide. Whatever the things that we are going to talk about now in the eventual slides. So you have to understand that whenever you give an ECG report, first try to, the moment you look at the ECG strip like that, see I have all these ECG strips here. The moment I look at the strip like that, I'll have to first do the DC, all these things we have done in the first lecture, that's the reason I'm not telling now. So the moment you look at the ECG strip, we'll calculate the heart rate and then see whether every waveform is right next to each other or not, whether they are in the rhythm or not. Then there is a beautiful measurement which is called as a mean electrical axis, which gives you a suggestion of whether it is a left heart failure or the right heart failure. And then whatever the waveforms that you're studying, try to establish a relationship between them, like in the previous slide we did, right? Whether there is a P wave for every QRS complex or not, whether the P wave is normal in shape and size or not, whether the QRS is a normal shape and size or not, are the Q waves deeper, are the S waves deeper, how is the shape of the T wave, is the shape of the P wave same in every single beat, every single waveform or not, okay? These are the things which gives you very, very crucial information about the performance of the heart, okay? And that you can correlate with the clinical presentation of your patient. Let's start. Now, this ECG tells you about the P waves. Now, if you see here, the P waves are really wide and they are tall. And some of the P waves are also like a little bump. So this is nothing but when you have, if the P wave is wider and taller than the normal wave, it means that the current which is generated, it's taking long to finish off your contraction. It is taking longer duration and it's taking more voltage. When does that happen? When both the atria so P wave is talking about the atria. So when both the atria are enlarged, so it might take a long duration to finish the contraction. It might take higher voltage to pass on to cover the entire atria. Okay, so biatrial enlargement. There is a slight difference here also. For example, if there is a left atrial enlargement, then you see a different form of a P wave. If it's a right atrial enlargement, you see a different form of P wave. Let's not get into the details of that, but I just want you to help you understand. By just looking at the ECG strip, you can talk about the structure of the atria. Okay. Now, coming to the Q waves, what we said, what are Q waves? Q waves is basically about the interventricular septum or conduction through the bundle of his. Okay. Now, the significance of Q wave is, it said that deep Q waves are considered as the pathological Q waves. Okay. It talks about the hypoxic condition. It talks about hypoxia or hypoxemia. It is correlated with that. So those tachypnic patients, the patient who are coming in like, panting and breathing, all those shallow breathers. So in those patients, you will definitely see a deep Q waves. So deeper the Q waves, sometimes, I would say, to me, always deep Q waves is an emergency. And so even if my patient is coming walking and all, if I see a pathological Q wave like that before, so I make sure that when my patient is in right lateral recumbency, they can be even more compromised. So I make sure that I pre-oxygenate them. Or, I put them on oxygen, low grade, like 1 liter or 1.5 liter of oxygen while I'm actually doing my echo. Okay, I don't want them to collapse on my table. You can do that. Pathological Q waves. If you see Q waves which are deeper than 2 small squares, and if it is a pug, then definitely pre-oxygenate them. Okay, or give them some time. Or sometimes, you while doing your cardiac examination, give them small breaks. Get them off of the lateral recumbency. Allow them to walk a little bit. You can do those things. You can take a chance with that. Okay. Now, coming to the, if both P wave and QRS complexes, if both the P wave and R wave are tall, then it means that both the atria as well as the ventricles are enlarged in toy breeds. Or in other words, if it is a larger dog, if it's a medium or a tall, big dogs, then if you see really tall waves, both the P waves or the QRS complex as really tall, it means that you are probably witnessing a DCM case. Okay, so if you have an echo machine, if you're planning to take up the echocardiography or a heart ultrasound, just go ahead and see. You will see a big difference in the size of the heart. You see all rounded and bulged up heart. If it is a toy breed, you will see that you will have a lot of regurgitation because of the variation in the size of the heart. If it is a medium or the large size dog, you will see that the valves, that mitral and the tricuspid valve, really spread out. The entire wall, the myocardium is very thin. It is all bulged out. You can see that kind of thing. Okay. By just looking at the ECG strip, you can actually tell about the structure of the heart. Okay. Now, coming to the R waves, if only R waves are really tall. The P waves you see here, the short P waves. Only the R waves are enlarged. It means that the ventricle is taking higher current and longer duration to contract. So what does it mean? It means it's only the ventricular enlargement. See, we all know that when a patient is going through congestive heart failure, so in congestive heart failure patient, it's basically the left heart that goes bad first. So when you see the left ventricular enlargement, you see really tall waves. Okay. Now coming to the S waves. Now this strip is not an inverted strip, guys. If you can look into that, try and understand here. So there is a first small bump, and then you have a tall, small R wave and a deep S wave. Then comes a T bump. Okay. So deep S wave, especially only the deep S wave especially, is considered as the right ventricular enlargement. It's suggestive of the right ventricular enlargement. Okay. So we know it's the right heart failures. Ascitic patients go through a right heart failure, or maybe it could be just the right heart, or it could be an entire DCM case. But in DCMs, you do not see an ECG like that. You see really tall R waves. Also, you can also see the deep S waves, but if you see only deep S waves, it's considered as specifically that right ventricular enlargement. Okay. Now you see in the third strip, you see weird form of wide and tall, shapeless R waves, Curious complexes. Now these are called as ventricular premature complexes. What does it tell you about the ventricular premature complexes? It means these are the signals which are generating from the ventricular myocardium. Okay. Now this VPCs, gentlemen, if you even have one single VPC, it is abnormal. Now, when do I take a call of treating these VPCs? When do I start putting them on the medication, on the sotalol, orally or not? When do I do that? If you have, discrete VPCs, like if you see one VPC, okay, you have to take a long strip of ECG. Sometimes I even finish an entire roll. See, I can show you an example here. This entire thing, you see a lot of VPCs here. I have finished an entire roll. I have many ECG strips here. These are all VPCs. Okay. Now, what I do is I take the VPC, I take the strip, entire roll, and see how many VPCs are there I count. Ideal way to start looking into it, to understand if they need to be treated or not, is to put them on the Holter monitor and count the number of VPCs in 24 hours. And if they are beyond 5,000, that is when we have to start treating them. Holter monitors are not possible. So what we do? We take an ECG strip for approximately 3 minutes, extrapolate it to 24 hours, and then count it. So number of VPCs in 3 minutes, you extrapolate it to 24 hours, and if it is coming approximately 4,000 to 5,000, that is when you have to put them on orally. Okay. But if you see VPCs right next to each other, they are called as a cluster VPCs. Cluster VPCs must be treated, irrespective of frequency. Okay, they must be treated. Now, I want you to pay attention to this. This entire ECG is actually coming from only one patient. It was a boxer. In boxers, we know it. They are very classically, they show VPCs. So it's called because of a disease called arrhythmogenic right ventricular cardiomyopathy. Is very common in boxers. Okay. Let's not get into that right now, but let me help you understand. In the strip from the top right, the third strip from the top, you see there are 3 waveforms which are bizarre, right? Now, if you see that kind of shape, you consider that it is a VPC, it's a ventricular premature complex which is arising from the left ventricle. Similarly, from the bottom second ECG, you see there is a weird waveform, right? The second waveform is weird. Now that kind of VPCs, if you see, it is arising from the right ventricle. Okay, there's a slight change in the shape. However, whether it is a left ventricular origin or the right ventricular origin, they are considered as abnormal and they need to be treated if they are more than 5,000 in 24 hours. Okay. Now, if a boxer comes to me, so boxers are always suspicious patients to me, and it is also said that you should always keep an eye on your boxer patient. So, right, if they come like 4 or 5 months old puppy itself, just take a basic ECG strip, allow it to run around for 15-20 minutes, let him play around, then come back, and while it is panting itself, take another ECG. If you end up seeing even one single VPC, definitely take little longer strips, huh? If you see even one single VPC, that is the time you counsel the pet parents that these things are not normal. Okay, you have to counsel them that they should come back maybe in another 6 months or 8 months or 1 year based on how many VPCs you see. And you have to tell them that there could be sudden cardiac death because if the frequency of these VPCs go up. Okay, so you have a patient for lifetime. You have to keep track, and we can just do it by doing only simple ECG. You don't need don't need a lot of equipment to identify a probable cardiac patient. Okay, just an ECG is more than enough, right? So these VPCs are nothing but the cluster VPCs. If they're more in succession, right? You need to treat them. if you see strip like that, oh, definitely. In that little small strip of about 40 boxes, if I'm seeing almost like 9 VPCs, I am going to put it on oral medication. Okay. So this is a very unique ECG. It's called as a right bundle branch block. You do have one VPC in here in the bottom strip. So when you have a right bundle branch block, it means the SA node generates a signal, it comes down to the AV, it passes through the bundle of His, but those bundle of His are dividing into two, right? Into the left bundle and the right bundle. So this signal is not passing into the right bundle, it is passing only through the left bundle and it's causing the left ventricular contraction, okay? So these right bundle branch blocks are not very significant. It can be even, the patient could be absolutely normal, it could be just an incidental finding. But why did I was fortunate enough to get this ECG because this patient has come to me. I'll show you about the details of this patient when we do the cases in the last lecture. But this patient has come to me with a complaint of exercise intolerance. It was a CRPF dog. It has come to me the complaint of exercise intolerance. Thoda sa kaam karta hai, madam, and baith jata hai. And when I looked at the echo, it was so unique. It had a lot of structural changes. It was going through a congenital heart defect also. So there were multiple things when it came to this dog. We will discuss about this in our last lecture. It was a beautiful case. Now, ventricular bigeminy. What is a ventricular bigeminy? In this, you see one normal wave and the next wave is a VPC. One normal, one VPC. One normal, one VPC. So honestly, this was a patient. We have just done it, done an ECG because it was a really old patient. So it hasn't come to me with any sickness or anything. It was just a 14-year-old dog, and I wanted to see. I do ECGs on a regular basis for all my geriatric patients. So ventricular bigeminy was not of its clinical significance much in our patients. However, in humans, it is considered as an emergency. Now, just like a ventricular premature complex, there could be ectopic signals. It means that a beat can arise from anywhere else in the atria apart from the sinoatrial node, and they are called as the atrial premature complexes. Where is the atrial premature complex in that? I don't know if you're able to see this, but there is where the Mowgli is written, where you see a 9Y on the top, right next to underneath there, you see one waveform which is closed. There are two closed R waves, okay? That is your atrial premature complex. In atrial premature complex, you do not see a P wave. Why? Because it is not being generated from the sinoatrial node. Okay. There is an ectopic signal which is generated anywhere else in the atria, and fortunately or unfortunately, it just passes through the atrioventricular node, and that's what is generating the ventricular contraction. And that's the reason you see no P wave but QRS complex. Okay. Atrial premature complexes are not, serious considerations when it comes to the treatment. It could just be an incidental finding. Coming to the most crucial part, we have read about so many different types of arrhythmias. There's so many different names. Though I didn't get into the details of the names because conceptually I wanted you to understand that a signal which is not generated from the regular conduction system is can lead to an arrhythmia. Okay, so then with these cardiac arrhythmias, the ones which need to be are clinically manifested and needs to be treated. Okay, now let's look at the signals which are generating slow, the bradycardias, okay, bradyarrhythmias. Brady means slow waves, very slow waves. Now, if you end up seeing a ECG waveform where you calculate the heart rate, and if the heart rate is approximately 40 or 50 beats per minute, okay, and then you should have a doubt. Why are these? I mean, is it actually a bradycardia or not? So for that, sometimes, the heart rate can slow down because of the vagal system also. We all know this, right? Because it is neurohormonally regulated thing. So what if the signal is not because of the sinoatrial node defect, or it could be just because of something going around in the systemic, in your other systemic changes? How do I differentiate it? There's a standard test which is called as an atropine response test. Very simple, guys. Just weigh the patient and take an ECG. When the patient arrives, okay, I feel if the ECG, the number of beats is just 40 or 45 beats per minute, I'm not comfortable with that slow rate. I go take 0.04 mg per kg, the standard dose of atropine, and inject it. So it leads to the stimulation. If after giving the atropine, if your heart rate increases, listen to me again. After giving the atropine, after 20 to 25 minutes, you need to take a repeat an ECG. And if you see the heart rate has increased, it means that it is called as a negative atropine response test. What does that mean? It means that whatever the slow heart rate was not because of the heart. So you're comfortable. It's fine. That's okay. On the other hand, if the atropine response test, it means that even after giving the atropine, the heart rate does not increase, and it's still slow. It is bradycardic. It is like 40 or 45 beats per minute. Then that is because of the sinoatrial node, and it is definitely a heart problem. Okay, it means the number of beats which are generated from the sinoatrial node are slow, are less. That's the reason you're seeing the bradycardia, and that needs to be treated. So if you're having a bradycardic patient because of the sinoatrial node, which is not normal, then you get patients which are, it will show long, big gaps, could be sinus arrest. They could be very, very slow. Number of beats could be very slow. So usually they end up showing the episodes of syncope, and you see, which is called as a sixth sinus syndrome, and it is very common in pugs, especially 4 or 5-year-old pugs. Usually I have many patients like that. They just come with a complaint of, ma'am, it suddenly has gone down like that, and then in another 2 minutes is all absolutely just woke up, it's all fine, and running around and sleeping. So what's the difference between a syncope and a fainting episode, or maybe an epilepsy, a feeble epilepsy? See, in an epilepsy, you see that the patient passes urine or stools, and it has fidget, it's jittery, it may or may not have fidgets. On the other hand, a syncope patient, you do not see any of this. When a patient falls, because of the heart issue, is not going to pass urine suddenly, it's not going to have any kind of drool, or it will not show the passing of stools or anything. And in few seconds, it's all up and normal, as if nothing has happened. That is considered an episode of syncope. Okay. Medical management of syncope, honestly, there is nothing to manage medically syncope. The only treatment of bradyarrhythmia is to put another pacemaker, because you have a sinoatrial node which is not normal. Okay. But in our country, we know, though people have tried putting on pacemakers, there are a couple of clinics who have done a wonderful job with it, but I don't know if they're regularly treating the patients that way. So how do I treat my patients? I have put them on isoprenaline, because there are a lot of papers available in human medicine that they say that, they have tried isoprenaline. Earlier, isoprenaline was available as oral form, but now I don't think it's available. Mostly it's only injectable. It does help in maintaining the heart rate to a certain extent. I have had patients who have lived for a few years with isoprenaline. The episodes of syncope goes down, but they are usually hypoxemic. Sometimes they even, gasp a lot. So putting them on bronchodilators can really help in breathing better. But they are not going to shoot up the heart rate, but the patient is definitely going to feel better. So the specific treatment for bradycardias or sixth sinus syndrome is to put a pacemaker installation. Okay. Now coming to higher heart rate ones, okay, tachycardias, treatment of tachycardia, which is originating above the ventricle, the supraventricular tachycardias. So all those patients which show beyond 250 or maybe approximately 300 or even beyond 300 heart rate, only then they are considered as a supraventricular tachyarrhythmia that need to be treated with an emergency. Okay, so when you look at the strip of a supraventricular tachycardia, you really don't see a normal P wave, but the QRS complexes is absolutely normal, and they're sharp and narrow like that, right next to each other. Absolutely regular rhythm. Okay, they need to be treated, guys. Supraventricular tachycardias are very common, even in clinical conditions like, extreme sepsis, or you can even see them in GDV cases. You see supraventricular tachyarrhythmias, even in poisoning, you see that. So those cases, you need to control the heart rate, or it might, it might get into what you call renal failures, or just because of the very little perfusion. So there is hardly any renal perfusion, so it can lead into that. It's an emergency that needs to be treated. Patient usually comes recumbent, hyperventilating, and when they go, when they show supraventricular tachycardias. Okay, so definitely the choice of drug is diltiazem. What does it do? It slows down the passage of number of beats from atrioventricular node. Okay, it causes the blockade at AV node. So the number of beats that are going down are lesser. So, that's how it reduces down the heart rate. On the other hand, if there is tachycardias because of the ventricles, that is the ventricular tachycardias, how do we treat them? The concept is, if the ventricular tachycardia or the ventricular rhythms are less than 160 beats per minute, we normally don't treat them. It's considered kind of okay to wait. But if it is beyond 160 beats per minute, ventricular rhythm, then you must treat. How do we differentiate between an SVT or supraventricular tachycardia and ventricular tachycardia? It is like, if you do not see a P wave, then it is an SVT. If you do see a P wave, and you see P wave, Keras complex, P wave, Keras complex, they're very narrow ones and they're right next to each other. And if it is beyond 160 beats per minute, then you treat them. And ideally, you see ventricular tachycardias, in many, many conditions. Sometimes even in anesthesia, you come across these things. Now, what you need to do, put them on IV lignocaine. Okay, IV lignocaine has a wonderful transient effect on the conduction of the rhythm, conduction of the conduction capacities. So the way normally we say is like start giving a small bolus and then put them on CRI once the heart rate stabilizes less than 160 beats per minute. Okay. But when you have these persistent ventricular tachycardias, but my patient is kind of active, it's walking around, I have stabilized the heart rate to approximately 160, but it is not going beyond down beyond that, then you end up giving them, you can put them on orals like propranolol, procainamide, atenolol is, though it is short acting, it's considered as a pretty good drug for a short duration time. It's pretty good. So propranolol also available as injectable form to treat the patient, but ideally IV lignocaine works really good in ventricular tachycardias. The most common ventricular tachycardia you see is a GDV patient. You see ventricular, they go through the VTs, and that's when you know that you have to stabilize it by putting them on IV lignocaine. Okay? Now another beautiful table. It's a very concise one. Click a picture, go ahead, paste it on your table. This talks about the different cardiac drugs. This is just the classification of these drugs, about class 1, class 2, class 3, class 4. This is all given in the books, but this is just a concise form to help you understand the mode of action of these antiarrhythmic drugs. How do they work and where do they work? Okay? So most of the beta blockers that we use in our cardiac patients, whatever they, to maintain the CHF, the regular patients, these are not the class of beta blockers that we use for that thing, but atenolol is one of the most common ones. In BPCs, I end up using sotalol. Everyone does that, sotalols. Sotalol is really good drug, can maintain it for really long time. I've even tried recently in the cat and it still works wonders. Arrhythmias, which are like atrial fibrillation, the supraventricular arrhythmias like atrial fibrillation is your diltiazem, digoxin works wonderful. You can put them on really, really long time also on this drug for lifetime, especially all those DCM cases where you have severe left atrial and the right atrial enlargements, or patients who are in almost stage C2 congestive heart failure due to mitral valve disease. They are, or mostly they end up showing irregular rhythm, which is nothing but the atrial fibrillation. So diltiazem works really well on them. Okay. Now, this is a comparative analysis of what drug to be treated for which disease and what dosage is that. So this slide alone will take about half an hour if we keep talking about it. So just take a picture of it and start reading it. Most of these drugs are very, very commonly used except for verapamil, which I have not used it. If anyone has, please do share their thing, because we normally don't use this. Lignocaine works really well. So except for that, all the other ones are pretty commonly used, okay? And the dosage is defined. Same thing about the ventricular antiarrhythmic drugs. Take out a picture and paste it again. So procainamide I have not used because refractory ventricular arrhythmias, those patients, they collapse. I have not come across a patient who is on the continuous VT and I put it on lignocaine and still not responded. Doesn't happen, the patient dies off. Okay, so I have not used a procainamide thing. In human medicine, it is most commonly used, especially if they are putting multiple pacemaker installations. Sometimes it is also said that a patient which is, you have atrial fibrillation and you do those treatments of, trying to burn them up and trying to maintain the heart rate, then they end up getting into ventricular tachycardias. Ventricular tachyarrhythmias, they do not respond. They end up having a persistent ventricular tachycardia. In those patients, procainamide is used, but I have not. Amiodarone is very commonly used orally. One of my mentor shows a very high favoritism to amiodarone, and it does work pretty well, especially in stage D patients where you see extremely enlarged heart, and they are starting to get refractory to your congestive heart failure treatment. Then amiodarone is something that you need to consider. Okay. Now, one of the very common tachyarrhythmias or changes in the ECGs that we come across, it is not definitely a rhythm change, but it is a change in the shape of the wave. That is, whatever the T wave are, it looks really tall and prolonged. This is suggestive of hyperkalemia. So we all know that, all the renal failure patients, they show this. But apart from that, they could be a high potassium content because of other reasons, other systemic reasons also. Then you see a hyperkalemic condition. So when the patient comes to me with showing you really tall T waves, it's an emergency. Then I will share you the case. I have even showed it in the last lecture. So hyperkalemic patients, there are multiple different ways of treating them. I find using using 25% glucose is one of the most favorite ways of doing hyperkalemia. So far, God's grace, I've never failed in it. So I used high glucose, high percentage of glucose, 25% or even sometimes 50% based on the type of the hyperkalemia I see. And so what you're trying to do, you're trying to push potassium back into the cells. Trying to put potassium back into the cells, okay? And so hyperkalemic patients, once you stabilize them, you have to keep looking into what are the causes of hyperkalemia, whether it is a renal failure or not. If it is a renal failure, you have to treat that, because if you don't try to address the major cause of hyperkalemia, then you end up pushing the patient back into it again, okay? You end up worsening the patient. So sometimes those cats with neurological disorders, like they come down with a complaint that my cat's like walking only with the support. It tries to look at the walls and try to walk with the support. Now those cats, there's a very common, you see ventroflexion, another very classic sign of hyperkalemic cat. Okay, look at the serum electrolytes. If there is a high potassium, start using oral medication, which can put. Now we have lots of beautiful drugs available to bind out the potassium in veterinary medicine also. Earlier, I used to use the human ones and make a very diluted solution, titrate the dosages and give it to the cats. Earlier I used to do that, but now I have a lot of beautiful drugs available. Now, coming to almost the end of my presentation here. So what does an ECG talk about? You need to understand something, that an ECG will tell you about the electrical conduction system of the heart. Though we have few limitations, but this is the only modality which will talk about the electrical system. It will talk about the rhythm. It is going to talk about how many beats are generated. Okay, so there is no other way of identifying a cardiac arrhythmia except for taking an ECG. It's that crucial. So we have seen multiple examples of how the changes in the waveform, how the number of beats, how the number of how the frequency of the waveforms talks about. You know, it talks about what is the clinical presentation of your patient, what it is going through. Okay, so it is going to, so ECGs talk about the rate, it talk about the rhythm, and it talks about how the heart is oriented inside the chest. And sometimes, you know, ECGs are very, very beautiful modality. Honestly, the ECG is a beautiful modality that can talk about the preventive things also. For example, we just talked about the VPCs in boxers. You know, one single VPC in a boxer, you know, you can counsel the pet parent that it can get into, it can increase in frequency, it can become an emergency. So keep track of it, keep coming down every 6 months, get your ECG done, to make sure that, you know, we try to curtail it down. If the number of VPCs goes up, you can just start the preventive medication on them. There are certain limitations of ECGs also. For example, ECG will not tell you about anything about the valves, right? It is not going to tell you about the heart valves, how the heart valves are. Similarly, ECG will not tell you about the thickness of the wall. Some of them do, but not all, the thickness of the wall. Okay, ECG will not tell you anything about the pericardium, right? If it's going through any kind of issues with the pericardium, it is not going to tell you about that. However, in my opinion, this is one of the most affordable diagnostic modality, and it talks so much about the electrical changes, it talks so much about the contractility, it talks so much about the conduction, and also you can correlate it with the patient. It can also give you a lot of predictive value also. So that is all my talk today, and yeah, it's nevertheless to thank your mentors. So these are my mentors, both from India and abroad, and I keep learning from them a lot. They're still guiding me, and if you have any questions, I'm willing to take them up.
I think this was a wonderful session, and there are, I think it was so much self-explained that very few questions are there. One question is there, ma'am, that what is the meaning of deep 5 waves, S waves, sorry.
Yeah, deep S waves, I was trying to explain you, is about right ventricular enlargement. It has been attributed to the right ventricular enlargement. See, S wave is about the contraction of the myocardium all the way up towards the atrioventricular junction. Okay, so if it is taking really long duration, especially if the ventricle, the wall of the ventricle, left or right ventricle is very, if it is very enlarged or if it has become very thin, then the S waves become even more. It takes longer duration to contract. So that is when you see only exclusive deep S wave is to see it is attributed to the right ventricular enlargement. However, if both the right and the left ventricles are enlarged, like in DCM case, you don't see a deep S wave. You see an entire QRS complex, which is very, very tall. Okay? Any other question?
The next is sotalar dose in cats.
I have used sotalol both in dogs and cats. Recently, it just slipped out of my tongue, but yeah. So this case, let me show you if I have my strip right here. It's the same 0.5 mg per kg body weight. Sorry, but I use the same drug dosage as in dogs, which is 0.5 mg per kg body weight. I don't know if you're able to see this using the strip. Let me know, Dr. Vishal, if you're able to see this. Do you see the strip? I'll just run through. I'll just run through the camera.
I'm a little away from the camera. This is too near. This is yes. Yes. I think.
Is it okay?
You can see. Yes.
Now, if you see the strip, you will come across the lots of VPCs in here. Can you see that?
Yes, ma'am.
Did you see? Oh, there are lots of VPCs here. There are lots of abnormal beats here. And this strip is kind of slow for a cat. So the way the patient, I'll show you in my last lecture about this case, because it's the most recent case. Just last week I got this case. So the clinical presentation was the cat was just showing a dry hacking cough, the way the dogs show, in mitral valve degeneration. It's a very, very simple thing. It was like just a dry hacking cough. And I'm like, okay, this doesn't look normal. So I started asking questions. Have you seen this before? It was just a 3-year-old cat. The 3-year-old cat showing this is not normal, right? And the cat has been regularly vaccinated. It has been, I am seeing that cat since it was a small little kitten. So and when I saw the VPCs, it just blew my mind because so many VPCs in just a strip, small strip is not normal. When I went ahead, took there's this ultrasound. So I don't want to reveal the surprise now, but it was really a wonderful case. So if this strip is before the thing, I have another strip. See, I'm an old school person, so I like doing all these things. Okay, Dr. Vishal, let me know if you're able to see the strip here.
Little bit. Yes, we can see.
Now in this entire strip, the same cat, after 3 days, no VPCs. 0 VPCs.
Amazing.
Something we did to that cat. We will reveal it. Let's keep it as a surprise. Okay. Yeah. Any other question?
Wait.
I am not able to read in my chat box. Okay, wait, shall I?
You can try.
Can you please this? Okay. Yeah, now I'm able to see. What is, okay. Please share the presentation. Okay, we will try to do some, he's going to share it online, right, Dr. Vishal?
Yes.
You're going to share it online, right? Okay.
Yes.
Okay, everyone asking for share. Where is that? Coding of ST segment. Fantastic question. Yeah, Dr. Atul has asked a very beautiful question. Coding of ST segment. Dr. Vishal, this was probably a voluntary miss, but beautiful question. Thanks for asking that. ST segment depression or coving, ST segment elevation, they are of huge significance in human medicine, but in veterinary medicine, when you see deep ST waves like going sharp like that, ST segment, if it is not isoelectric and it's going sharp like that, it is considered as a T wave abnormality, or also it is considered as a myocardial infarct. In our patients, ST segment elevation or depression are not of huge clinical relevance. But if I have, for example, if I have negative T waves, and if they are big and wide and deeper, then they are kind of misunderstood as ST segment coving. And such deep and wider T waves, I myself, I have said this in last lecture, but I'm also doing a lot of my research because in human medicine, you have quite a few papers that say that wider and wider T waves are correlated to hypothyroidism, and I am seeing that a lot in my patients. Most of my hypothyroidic patients, they have wider T waves. They have deeper T waves. So Okay, so you can ask me a question. Okay, if I correct hypothyroidism, is it going to get back in there? I don't know yet. For last 3 years, I'm trying to maintain my patients and I'm trying to redo my ECGs, though I'm not seeing a lot of difference, but probably, correcting the hypothyroidism in our patients is not a piece of cake either, right? Because you do that only, by the time they're hypothyroidic, they are already very clinically compromised. They are obese, or they are showing chronic skin infections, or they are already into osteoarthritic changes. There's so much going around, right? So ST segment coving or elevation is not of big clinical relevance, except for looking into hypothyroidism in our patients. Okay, I hope I have answered that question to you, Dr.
Yes.
Any other area? You were asking me about something, Dr. Vishal. I'm sorry, I missed it.
There was a question. Can you please speak a little about escape beats? Escape beats,
yeah. Yeah, not only that, but there are many abnormalities we have not detailed, because this presentation of mine was basically trying to help you understand how a variation in an ECG happens, and whatever the variation is happening, how do you clinically correlate it? Escape beats, they basically originate from the AV junction, and escape beats can lead to AV dissociations. They are junctional rhythms. Are they of clinical significance? Probably not much, until and unless there is lot of difference in number of beats originating from atria and ventricle. If they are not normal, like in third degree AV block, until and unless they're showing that, they're not of clinical relevance. But yes, it needs an entire big lecture about escape beats. So if you want, I can post some literature to Dr. Vishal, and maybe you can post it on the group, Doctor, because it's an entire big subject to talk about.
Then we can share.
Okay. Thank you.
This is the next question. You can come after that. This coving of ST segment. There is a question. Please explain right side and left side origin of VPC again.
Now, if you see no P waves and a tall QRS and a tall and wide waves, then it is considered as the VPC, which is originating from the left ventricle. If it is left ventricle, you see a tall QRS complex. They're wide and tall. These are the most common VPCs. On the other hand, if you see a wide Q and a wide and deep S wave, it just looks like an S. A wide Q and wide and deep S waves, then it is considered as the VPC, which is arising from the right ventricle. I will share you an image, Dr. Vishal, a slide, an image with comparative right and left ventricle VPCs, and you can share it in the group. See, whether it is right or it is left, the most important thing about the VPCs is the frequency. If the number of VPCs are more, or if they are clustered, no matter what, you will have to end up treating them. They are an emergency, or they are going to be an emergency very soon. Okay, so if you come across one VPC, even for example, if you put them under anesthesia and you see that the number of VPCs, if you one incident suddenly is a bump aake chala gaya hai, there's something that, please consider it as a cardiac patient. Go ahead. Once the patient recovers, after 2 or 3 days, ask them to come back, take long strip of ECGs. Please do that. If you come across one single VPC, make sure that you call them for a follow-up. Make sure that you allow the patient to run for 10 to 15 minutes. Take an VPC. You might see the ECG. You might see number of VPCs going up because of the increase in the heart rate. So it's an emergency. If there are more than 5,000, if extrapolated more than 5,000 per 24 hours, they need to be treated. Okay.
Only elevated R amplitude, does it need medication?
No, it says pathophysiology of a VPC. Pathophysiology, a beautiful word. Pathologically, VPCs are pathological, definitely yes. They are originating from the left ventricle. They are not originating from the SA node. And pathophysiology of VPCs is they are going to get your cardiac output down, because the ventricle doesn't have the capacity to contract as good as it contracts because of the entire regular QRS waves. Okay, so that's the reason the cardiac output of your patient is going to go down. More the number of EPCs, less the cardiac output. Okay, that's how it's going to affect. Only elevated R wave amplitude does it need medication in a senior healthy dog. Please understand this. How tall is your R wave? A tall R wave which is going beyond three big squares in a patient which is like a 13-14-year-old and it is a toy breed, then you know that you're handling a congestive heart failure patient because of the left heart enlargement. If you have a patient like a geriatric patient and is not showing any signs, ma'am, still a tall R wave, you have a patient in your heart, man, Pimo-Benden ka case hai, pakdo aur echo karo. Okay? Any tall R wave, it's not normal to me. Anything that is beyond 3.5 large squares is not normal to me. Okay? Go ahead. Whether it needs a medication, you have to decide upon it needs a medication or not based upon your echo. However, ma'am, echo available nahi hai, dur tak nahi hai, kya kare? Chest X-ray le lo. Take a chest X-ray. Now, lateral chest X-ray, anything right lateral, left lateral, koi baat nahi. Beyond the heart, if the heart is like that, and in the caudal lung lobe, if you see white patches, opacities, you have a cardiac patient in the heart because it is a pulmonary edema.
Yes.
आपके पास congestion है heart में. It definitely needs a treatment. कम से कम उसको stabilize करो, थोड़ा सा उसको relief दो. Go ahead, put it on furosemide. Go ahead, start it on load on Pimo-Benden. You see, clinically, your patient will feel very good. Mostly, geriatric patients, it's not easy to identify. You know, if they are not showing classic signs of heart failure, like they say, ma'am, my dog is old. That's the reason it has slowed down. God damn it, it has not slowed down. It could be just an exercise intolerance. It is not showing dry hacking cough in the night. नहीं मैम उसको ज़्यादा ठंड बर्दाश्त नहीं होती है तो रात में हल्की सी खांसी आती है. हल्की सी खांसी नहीं है. It is a clinical patient. Okay, so start asking relevant questions. Get little more deeper. If you want, no ma'am, I need a confirmatory thing before I start my drugs. Okay, fine. Your patient, ask your pet parent. When a patient is in deep sleep, deep good sleep, रात में सो रहा है, ask them to click a video of 1 minute and share it to you. Or ask them to check at the flank and count the number of breaths per minute, sleeping respiratory rate. Anything beyond 30, you have a patient in your hand that needs to be treated. Okay? Did I answer that?
Yeah. Yes, ma'am.
Dr. Ayana, okay, she said, is there any percentage increase in the number of beats after atropine response test that we should look for to categorize the bradycardia or vagally mediated? Dr. Ayana, she is excellent at talking about ECG. She is a vet cardian. She herself has given a beautiful presentation on ECG. In my opinion, if my heart rate is even increasing by 5%, I need not treat it. But if the heart rate is not changing at all, then I need to. However, you know that if there is an increase, it is not something that you're treating for sick sinus syndrome. You just have a vagally mediated thing and you need not treat it at all. It's going to calm down. Okay? Now, significance of QT prolongation, does it always relate with hypocalcemia? There is a correlation of, I have not talked few things, electrolyte imbalances, I have not talked in detail because it's a huge lecture. So just looking at an ECG, you can tell about variations in calcium, variation in magnesium, variation in potassium. Yes. Now, QT prolongation, does it always relate with the hypocalcemia? You have to first assess the rate of the heart, if it is bradycardic or not. If it is not bradycardic, yes, it can correlate to hypocalcemia. But do you really see an emergency hypocalcemic patient coming down with any clinical signs of heart? You don't. Then what significance does hypocalcemia have? I really don't think so. If you have a cardiac patient on your table, whether you need to pump in calcium, I would never pump in calcium because calcium doesn't just work in one way. There are a million different ways. It's a secondary messenger. You know how million different ways. And one most important thing is it can improve the contractility. It just improve the number of contractile to sky high. So don't think of pumping calcium at all into a cardiac patient. Okay. Hypocalcemia, can it be an emergency? It solely by itself, I really don't think so, until and unless you're handling a post-gestational, post-parturient patient. Except for that, I really don't think it is having an impact on any. I mean, you're not really handling a exclusive cardiac patient if you're seeing hypocalcemia. Notched Cuirass complexes. Notched Cuirass complexes of fragmentation. There are beautiful literature available talking about it, but yeah, Notched Cuirass complexes now are considered as very important and needs to be treated because it talks about changes in the conduction in the ventricle. So I can post a literature in the group, but this is another huge subject, doctor. So I would definitely like to postpone it right now. Is that okay? Okay, good. Now, does a dog with atrial fibrillation require lifelong diltiazem and digoxin? That is Dr. Mahima asking. Another very brilliant student, vetcardian. Doctor, when you say an atrial fibrillation, once the atrial fibrillation has set, you know that you will have to end up reducing down the preload and afterload on the heart. It means that you have to make sure that the size of the heart goes down. Will the atrial fibrillation patient ever going to come down to the normal rhythm? I have not seen that happening because they always are the end-stage disease. So you have an end-stage disease patient in your hand. So it means that definitely you have to maintain the rhythm. It is going to be there. But if my patient is young and it is showing atrial fibrillation, so I am probably having a major congenital heart defect. Like I can show you a case, even in last lecture, I've shown you I have an atrial fibrillation where my patient was into idiopathic DCM, juvenile idiopathic DCM, just a 1.5-year-old German Shepherd coming as an ascitic and always breathless, is not putting on weight and all. So you have a patient in hand who is already the atria severely enlarged. They are waveforms originating from anywhere in the atria. Yes, of course you need to. Till your rhythm doesn't come back into normal, say you have to. But will an atrial fibrillation ever come back to normal? I have not seen that happening. So you have an answer in your question. Okay, if you're asking me, is that going to be a combination thing always? Trust me, the combination always works better than using one single drug. Okay? Some more informative present. Okay, okay, sorry, thank you. J point for myocardial infarction and how can we judge a J point? Beautiful question, Dr. Dolly Flower is asking. Now, let me tell you something. MI, myocardial infarcts, in our patients is basically we see those MIs as the focal infarcts. We do not see a huge infarcts in our patients. Why is that so? Now, if you look at the heart, now Dr. Vishal is going to smile because every time I talk about it, I'm going to show the image. I love this. This is a human heart, guys, model. I couldn't find the dog heart one. What's the difference?
थोड़ा सा पीछे से दिखाएंगे तो पूरा दिखेगा. Yes.
Now, what's the difference between a human heart and an animal heart is that this is a human heart model. Let me take out the area. I'll just come a little closer to show you something here. Now you see anything that is red, we all know that anything that is red is are considered as arteries and those which are blue are considered as veins. So if you see there are two major arteries which are originating from the aorta which supplies to the heart muscle and they are called as the coronaries, right? So those coronary arteries, one is the left coronary artery and the right coronary. The left one again branching into two major ones. Now, then you see small little branches, that's it. Thoda sa branching hota hai. If you end up having a blockade in any of the major branches on the left side, yaar major heart attack aaya tha, bichala pehla heart attack mein chala gaya, it's major. If you end up having a blockade in the right coronaries, yaar he had a heart attack and they put a stent, God grace is good. The right ones are usually not very critical. They give you some time to put the stents on and the performance is pretty good for a really long time. Ye sari kahani to maine bata di. How does it correlate with the MIs? So those blockades, it means that it is that particular area will not have the supply of blood and it is going to cause ischemia or myocardial infarction in that area. In our patients, if they have only 3 branches, in our patients, they have more than 300 branches, the collaterals. If you go ahead and, once Dr. Vishal posts the first lecture, you will see I have put an image, comparative image, where they have hundreds of collateral available in our patients. That is the reason the incidence of myocardial infarcts or MIs in our patients are negligible, क्योंकि इसने नहीं सप्लाई किया तो बाजू वाला आके ऑक्सीजन सप्लाई कर देगा. Okay, so that is the reason our patients do not go through a heart attack. Okay, that is the reason why. So when you consider a J point for a myocardial infarct, do I really see the incidence of J point ECGs? Probably out of hundreds of ECGs I might have taken, probably I always skipped it. Agar hua bhi hoga to it's only of academic importance to me. Okay. Ventricular tachycardia and supraventricular tachycardia. Try to simply understand. When you say tachycardia, number of beats are much higher than normal. ठीक है, इतना समझ आ गया. Now, whether it is supraventricular or ventricular tachycardia, one single difference. In the ones which are supraventricular, originating above the ventricle, you do not see a P wave. I repeat again. If it is a supraventricular tachycardia, you do not see a P wave and you see QRS complexes right next to each other. On the other hand, ventricular tachycardias, you do see a P wave. So it's like PQRST, 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 but they are in more number than the normal. ठीक है? डॉक्टर विशाल समझ आ गया?
काफी हद तक.
तो सबको आ गया. I'm done. You're the only person I can see. So.
Yeah, I can understand. Yes.
Okay. Am I done with the questions? Ma'am, can we take an ECG in a standing position or sternal recumbency? Absolutely yes. Is there going to be a difference? Definitely no. All pugs, probably you missed the first lecture, Dr. Akhil, but yes, you can definitely take an ECG. Those patients who are tachypnic and they do not want to lie down, they are showing the wide stance, they are hypoxemic, or they're severely compromised in the breathing. Yes, please go ahead and do a standing ECG. You do not see a lot of variation if you make them stand or make them lie down. Sternal recumbency, yes. But the only thing when you take an ECG in the sternal recumbency is you have to make sure that you put a proper insulation. और फिर रखना, क्योंकि ECG clips का जो steel होता है, you have a lot of chances of touching onto the table when you do it on a sternal recumbency. ठीक है? And then you see a lot of that electrical variations. ठीक है? वो छोटा thick wave आता है, तो that is mean that it is electrical interference. But you can definitely do an ECG. Thanks for asking that question. It was a wonderful question. Yes, you can definitely do. कोई difference नहीं होता है. Dr. Sunita, another Vetkarian, thank you for that. So negative P wave, how to treat this arrhythmia? Dr. Snehal, another Vetkarian. So Dr. Snehal, when do we see a negative P wave? Whether a negative P wave is an emergency or not, I have seen negative P waves, especially in all those hearts which have an atrial septal defect. I do not know why that happens, but usually I have seen that atrial septal defects do show a negative P wave, but I don't think you need to treat negative P waves. It's probably normal for that heart. Okay.
So
just an example, I have one. So I'm absolutely normal. No one is treating me. So मेरा negative P wave है. कुछ नहीं होता है. They're normal. Am I done with the questions, doctor?
Yes, ma'am. With the questions you are done. You are superb, and your students are again too much too good.
Almost 100 people still. I mean, wonderful.
Still there.
Bore nahi hua hai. I'm so happy for that. Thank you.
I can understand. See, here when we are organizing a webinar related to these kind of subjects, these are so, I believe very few veterinarians right now, or very few percentage of veterinarian is doing cardiology, serious cardiology in their practice. So now, because these topics are a little, difficult and serious topics, so only those who are a serious cardiologist or they are planning to be a serious cardiologist, they are joining these sessions, and all are really very keen to learn everything. That is the enthusiasm you are seeing in the questions. And this is the magic you have while you are teaching the subject.
Thank you.
And this is amazing session, and the beautiful audience we have. thank you very much for making this community so successful. And I'm really sorry that we couldn't post that first session also. The actual problem is, Kanika says don't say these things in front of everyone. But the only thing is, the problem with these sessions are I have to sit with the tech team because these are very important topics. When they have some kind of problem in the, if I'm not sitting with the tech team, they can cut down the important session if they are having any video or audio quality. So I have to sit for hours to have to get this edit done. And in the last 2 weeks, I was not very, I was I was going a little busy. So in coming weeks, you will have the videos of all these 2 sessions uploaded. And thank you very much, ma'am, for this.
There's another thing that we can do, Dr. Vishal, for next 2 lectures. What we'll do is I'll pick up few slides, make it a concise PDF document, and we'll post it in the group.
That we can share right now, right there. Yes, that we can share.
So उसमें क्या होगा? They can quickly brush up. Probably audio will not be available, लेकिन कम से कम they will quickly brush up. Okay, ये हमने बात किया था. So that way, coming down for the next lecture, it would be helpful for them. Probably that these 2 lectures will be really helpful for the last lecture because we will be having quite an interesting talk in the last lecture. It will be going to be about my cases. And so, there will be some constraint with posting these cases online, but I will definitely.
You will mark that area of the session, and we will delete it from the we will not upload.
Only those who are in the publication will delete it. Rest of them will make sure that most of them will make sure that they are available, so that people can go and understand, because clinical presentation is very, very important.
You are the only person who even excited to tell all the secrets of your research and everything. But okay, I can understand that you don't want it to be shared online, but you want to teach everything to your students. That is the best thing.
It has all come through a lot of hardship, and I know it's not easy for everyone to go through all this. But you see, I am on a spree of establishing cardiology as a mainstream session. We really, because it's an emergency thing, we all are handling cardiology without our knowledge. Every single person is sedating. Every single person is putting the patient every single day in anesthesia.
All the surgeons on daily basis.
You are handling a cardiac situation out there. Are you playing with the heart? So aapko pata hona chahiye these things. So and all these things are available in the books. But all I'm trying to do is practically showing them how it happens in a patient. So I don't mind sharing it in a way that if it's helpful to my friends. But yes, important thing is these groups, the multiple groups Dr. Vishal has. So guys, groups are not available only for announcements. Take ECGs, machine खरीदो, 20-25 हज़ार से ज़्यादा नहीं होता है. Dr. Vishal भी दे देंगे, कोई बात नहीं. Do ECGs, okay? Start posting them. Start posting your ECGs online. You have my number available also. करोगे तभी सीखोगे.
And मैम, ये एक अकेला मॉडल ऐसी मोडालिटी है जो गांव में बैठ के भी कार्डियोलॉजी, एक बेसिक कार्डियोलॉजी किया जा सकता
है. अरे डॉक्टर साहब, आई हैव वंडरफुल फील्ड वेटनेरियंस. मेरे को ना एलिफेंट का ईसीजी आया है. बफेलो काउ का बहुत कॉमनली आता है. आई गॉट एन एलिफेंट ईसीजी. आई गॉट what do you call that, primate ECG. And it was showing ST segment elevation, and we had wonderful discussion with that vet. And he was a wildlife rescuer. उन्होंने मुझे भेजा कि मैडम मेरे पास ECG है, मैंने इसको किया है. मैंने कहा लाइव नहीं मैम, सेडेट करके किया है. But still we saw ST segment elevation. I had to study again the human ECGs to go back and explain it to him. See, I learned so much from these. So it's wonderful. Mutual education has been great. We all can do it. So yeah, go ahead. Please practice it. Auscultation ECG हर किसी को करना चाहिए. Please start doing it, and it's a mutual thing. We both can learn. There are hundreds of veterinarians in Dr. Vishal's group. So please go ahead and do it. This man is doing a wonderful job. I know how difficult it is to have that commitment of teaching for free. I have been doing it for past 6 years. It's a serious education, guys. It's not easy. So avail it. It's for your own benefit, and probably because he is a veterinarian, so he understands what it is, right? So, thank you for organizing these wonderful sessions. It's the second time I'm doing it, and I always enjoy it because जैसे ये sessions खत्म होते हैं, I start getting so many requests. Madam, Bed Guardians join करना है, आ जाए. Last time, because of you, it was a record that I included more than 100 people in one single go. जो मैं कभी नहीं करती. पर आज भी मेरे लिए इतना मुश्किल है उनको मेंटेन करना.
मैम इंक्रीज द कम्युनिटी बेस ना, बढ़ा लीजिए. आप तो अपना सोसाइटी को भी आप करिए ना, थोड़ा सोसाइटी में भी लोग.
Next session I'll talk about the society, how we are planning to start beautiful lecture sessions in society, but there's going to be physical lectures and trainings and all that. I'll definitely announce in the next lecture. I might also start some hands-on session personally. That also I will announce in the next lecture.
Wow, that's great.
Thank you once again, Dr. Vishal and all the audience. It was a wonderful session. See you in next week.
Thank you, ma'am. Thank you. Have a great day.
You too. Thanks. Bye.